Welcome. In this lecture, I want to take you through Patent Ductus Arteriosus in the preterm infant, from its very beginning in fetal life all the way to the management decisions we make at the cot side. The Patent Ductus Arteriosus is probably the single most debated cardiovascular problem in the neonatal intensive care unit. For more than 50 years, we have argued about whether to treat it, when to treat it, and how. My aim today is to give you a clear physiological foundation, to lay out the evidence on both sides of that argument honestly, and to leave you with a practical, gestational age-based way of thinking that you can apply to a real baby tomorrow morning. This is pitched for neonatal fellows and consultants, so I will not shy away from the controversies. Here is the shape of the next 40 minutes. I will start with physiology, because almost every management decision flows from it. We will look at why the ductus is held open in the fetus and what normally drives it to close after birth. Then I will explain why the premature ductus behaves so differently and tends to stay open. From there we move to the shunt itself, the overcirculation of the lungs and the stealing of blood away from the gut, kidneys, and brain. We will then tackle the hardest part, defining what actually counts as a significant duct and the long argument about whether to treat it or leave it alone. After that I will go through the full range of management, from simply waiting, through medicines, to closing the duct in the catheter laboratory or the operating theater. Finally, I will pull everything into a single practical framework organized by gestational age, and finish with the messages I want you to remember. To make sense of every treatment decision, we have to begin before birth, with the duct as a normal and necessary part of the fetal circulation.
Let me start before birth, because the ductus arteriosus is not a malformation. It is a normal and essential fetal vessel. In the fetus, the lungs are fluid-filled, and the pulmonary vascular resistance is very high, so very little blood needs to go to them. The ductus arteriosus is the muscular vessel that connects the main pulmonary artery to the descending aorta, and it lets the output of the right ventricle bypass those collapsed, high-resistance lungs and pass straight into the aorta to supply the body and the placenta. Roughly 90% of the blood leaving the right ventricle takes this shortcut across the duct. Two things keep it open. The first is the low oxygen tension of fetal blood. The second, and the most important, is a high circulating level of prostaglandin E2, much of it produced by the placenta and not yet cleared by the immature lungs. Hold on to that idea of prostaglandin E2 keeping the duct relaxed, because every drug we use later works on exactly that pathway. So why exactly is the duct open in the fetus? Three forces work together. First, low oxygen tension. In adult and newborn life, oxygen is the main natural constrictor of the smooth muscle in the ductal wall. And in the fetus, the arterial oxygen level is low, so that constricting signal is largely absent. Second, and most powerful, prostaglandin E2. This prostaglandin actively relaxes the ductal muscle. It comes largely from the placenta, and because the fetal lungs are full of fluid, they cannot metabolize it, so blood levels stay high. Third, the placenta itself, which is a continuous source of these dilating prostaglandins. When the baby is born and the cord is cut, that placental supply disappears, and the now air-filled lungs begin clearing prostaglandin very efficiently. Those two changes, together with a sharp rise in oxygen, are what flip the duct from being held open to being driven shut. After a healthy term birth, closure happens in two stages. The first stage is functional closure. Within minutes to hours, the surge in oxygen and the fall in prostaglandin E2 make the muscular wall of the duct contract. The vessel shortens, its wall thickens, and the lumen is squeezed shut. In most term babies, this functional closure is complete within the first day or two of life. The second stage is anatomical closure. Over the following days to weeks, the constricted duct undergoes permanent remodeling. The inner lining thickens into cushions, the smooth muscle in the middle layer dies in a controlled way, and connective tissue replaces it so that the vessel is sealed off for good and becomes the fibrous ligamentum arteriosum. The key point is that functional closure can be undone. A duct that is clamped shut but not yet remodeled can reopen if the baby becomes hypoxic, acidotic, or septic, and that is exactly what we sometimes see in sick preterm infants. Now the central problem. Why does the duct of a premature baby so often refuse to close? There are four interlocking reasons. The first is intrinsic immaturity. The wall of the preterm ductus is structurally underdeveloped. Its smooth muscle is thinner and contracts weakly, and the oxygen sensing mechanism that should trigger constriction is not yet mature. The second reason is heightened sensitivity to dilators. The immature duct responds much more strongly to prostaglandin E2 and to nitric oxide, so the very same hormonal environment that a term baby can overcome keeps the preterm duct relaxed. The third reason is failure of remodeling. Even when the preterm duct does constrict, its wall is so thin that it often does not develop the profound oxygen starvation in the muscle layer that is needed to drive permanent anatomical closure, so the vessel is prone to springing back open. And the fourth reason is illness. Respiratory distress, infection, and a generous fluid intake all raise prostaglandin levels and lower oxygenation, and they can reopen a duct that had begun to close. Put these together and you understand why a patent ductus is almost a defining feature of extreme prematurity, rather than a rare complication.
With the physiology in place, let us look at how common the patent duct really is, and what happens to it if we simply leave it alone.
Let me anchor the discussion with numbers, because they frame every decision we will make. A patent ductus is common, and it gets commoner the more premature the baby. Around 65% of infants born below 28 weeks of gestation still have an open duct on the third day of life. But here is the crucial counterweight. The natural history is closure. In the most immature babies, those at 24 weeks, only about 13% will close the duct spontaneously before going home. By 28 weeks, that figure rises to roughly 73%. And at 30 weeks and beyond, very nearly all of them, around 98%, will close eventually without any intervention. So the headline is this: prevalence climbs steeply as gestation falls, yet the underlying tendency, even in tiny babies, is towards spontaneous closure. Time is on our side far more often than a loud murmur at the bedside would lead us to believe. That single tension, common but self-limiting, sits underneath the entire treatment debate. Two cohort studies are worth knowing by name because they reshaped how cautious neonatologists think. The first is the work published by Koch and colleagues in 2006, which looked at the smallest babies, those weighing 1,000 grams or less, and showed that a meaningful proportion of them closed the duct spontaneously before discharge. Closure is simply not rare, even at the extremes of birth weight. The second, and the more influential, is the Irish cohort, published by Semberova and colleagues in 2017. They followed infants of 1,500 grams or less who were managed conservatively, and the duct closed on its own in essentially every survivor. The more premature the baby, the longer it took, but closure was the rule rather than the exception. The clinical lesson from both is the same. A duct that is still open at 1 week is not a duct that will never close. If we are patient, we avoid treating a great many babies who would have closed without us lifting a finger.
Now to the heart of why a duct can do harm: the shunt itself, which floods the lungs while starving the rest of the body.
Once the baby is born and pulmonary vascular resistance falls over the first days of life, the pressure in the aorta becomes higher than the pressure in the pulmonary artery. If the duct is still open, blood now flows the other way, from the aorta into the pulmonary artery. This is the left-to-right shunt, and it does two kinds of harm at once. The first is pulmonary overcirculation. Extra blood is driven into the lungs. The lungs become wet and stiff. The left atrium and left ventricle have to handle the returning volume and dilate, and the baby becomes harder to ventilate and more prone to pulmonary hemorrhage, and over time, to chronic lung disease. The second kind of harm is systemic steal. During diastole, blood that should be perfusing the body runs backwards into the low-pressure lungs instead. The result is reduced flow to the gut, the kidneys, and the brain. That diastolic steal is the mechanism that links a large duct to necrotizing enterocolitis, to acute kidney injury, and to brain injury. So a significant duct simultaneously floods the lungs and starves the organs.
So what are we actually worried about? A persistently significant duct is associated with a list of serious morbidities. Chronic overcirculation of the lungs, together with prolonged mechanical ventilation, is linked to bronchopulmonary dysplasia, the chronic lung disease of prematurity. The duct is linked to intraventricular hemorrhage and brain injury, and the elegant work of Klukow and Evans showed that it is low blood flow in the superior vena cava in the first hours of life that ties the open duct to bleeding in the brain. Diastolic steal away from the gut is associated with necrotizing enterocolitis, and steal away from the kidneys produces poor urine output and a rising creatinine. Now, here is the caution that you must carry with you. Association is not the same as causation. The patent duct is not only a cause of these problems, it is also a marker that this is a very immature and very sick baby. And this matters enormously because trials that have closed the duct early and aggressively have repeatedly failed to abolish these morbidities. If closing the duct cured the problem, those trials would have been positive. They were not. That single fact is the engine of the whole treatment debate.
If most ducts close on their own, and closing them does not reliably help, then the real skill is deciding which duct is actually significant.
So, if many ducts close on their own, and closing them does not reliably help, the central clinical skill becomes deciding which duct in front of you is actually causing harm. We call that a hemodynamically significant duct, and the single most important thing to understand is that significance is a composite judgment, never a single measurement. I weigh three things together. First, the duct itself. How wide is it, indexed to the baby's weight? And what does the Doppler flow pattern across it look like? A wide, unrestrictive duct shunts a large volume. Second, the shunt volume, judged on the echocardiogram. The ratio of the left atrium to the aortic root being 1.5 or greater, a ratio of left ventricular output to superior vena cava flow above 4, and reversed flow in the descending aorta during diastole all tell me the shunt is large. Third, and never to be forgotten, the baby's own response. Is this infant becoming more ventilator dependent? Is the perfusion poor? Is there a metabolic acidosis? Are the feeds not being tolerated? Is the urine output falling? And how premature is the baby? A modest duct in a thriving 30-week infant is a very different thing from the same duct in a ventilated 24-week infant. Put the duct, the shunt, and the baby together, and only then call it significant.
To make that composite judgment more reproducible, two structured tools are worth knowing. The first is the Patent Ductus Arteriosus Severity Score, often abbreviated as the PDA-SC, published by El Kufash and colleagues in 2015. It is a weighted echo-cardiographic score that combines the ductal diameter, the markers of shunt volume, and the degree of loading on the left side of the heart into a single number. Its value is that a high score in the first days of life identifies the infants most likely to need treatment and those at the greatest risk of chronic lung disease or death, so it helps target attention to the babies who will benefit. The second tool is the staging system described by McNamara and Segal in 2007. It grades the duct on two separate axes. The clinical axis runs from C1, a silent duct with no signs, up to C4, a duct causing systemic compromise. The echocardiographic axis runs from E1, a small restrictive duct, up to E4, a large duct with clear steal from the end organs. The philosophy behind both tools is the same, and it is a good mantra. Treat the stage, not the murmur. Recording severity in a structured way stops us from reacting to a sound and forces us to document what the duct is actually doing.
Let us turn to how we actually detect and characterize the duct, where the examination raises suspicion and the echocardiogram makes the decision.
Let me move to the bedside. What does a large duct look like clinically? The classical sign is a murmur, continuous or systolic, heard best at the upper left edge of the sternum. But I want to warn you straight away that the murmur is unreliable in exactly the babies we worry about most. In the sickest, most premature infants, a large duct is frequently silent, so the absence of a murmur never excludes a significant duct. The more dependable signs are the hemodynamic ones. The precordium becomes hyperdynamic, visibly and palpably active, as the left ventricle copes with the extra volume. The pulses become full and bounding, and the pulse pressure widens because blood runs off out of the aorta into the pulmonary artery during diastole. On the respiratory side, you see a rising requirement for the ventilator or for oxygen, worsening apnea, and in severe cases, pulmonary hemorrhage. And systemically, you see the consequences of the steal: feed intolerance, a distended abdomen,
falling urine output, and a metabolic acidosis. The bedside, in short, raises the suspicion. It does not make the diagnosis. For that, we need the echocardiogram.
The echocardiogram is the cornerstone of diagnosis, and in modern neonatology, it is increasingly performed and interpreted by the neonatal team itself as targeted neonatal echocardiography. A proper study answers 3 questions in turn. First, it characterizes the duct. It measures the diameter at the narrowest point, usually indexed to the baby's weight, and it defines the direction and pattern of flow across it. Second, it quantifies the shunt by looking at how much extra volume is loading the left side of the heart. The ratio of the left atrium to the aortic root, the ratio of left ventricular output to superior vena cava flow, and the pattern of mitral inflow all tell me how big the shunt is. Third, it grades the steel by looking for reversed flow in diastole in the descending aorta and in the vessels to the gut and the brain. And before any of that, the echo has a non-negotiable safety job, which is to confirm that the heart is structurally normal. I will come back to that in a moment, because it is the one mistake that can be catastrophic. The flow pattern across the duct, measured with Doppler, tells me a great deal about what the duct is doing and where it is heading. There are 3 patterns worth recognizing. The first is the restrictive, or closing pattern. Here, there is continuous left-to-right flow with a high peak velocity, above about 2 meters per second, and a well-maintained velocity throughout diastole. This is reassuring. It means the duct is narrow and constricting, the pressure difference across it is high, and it is on its way to closing. The second is the pulsatile, or unrestrictive pattern. Here, the velocity in diastole is low, below about 1 meter per second, with a large swing between systole and diastole. This is the worrying pattern, because it tells me the duct is wide open, the pressures on the 2 sides are nearly equal, and a large volume is being shunted. The third is the pulmonary hypertension pattern, with bidirectional or right-to-left flow, which tells me pulmonary pressures are high and should make me think carefully before doing anything to close the duct. Reading these patterns tones the echo from a yes or no test into a dynamic picture of the duct's behavior.
Let me give you the specific echo-cardiographic thresholds that are worth committing to memory, because these are the numbers that move a duct from interesting to significant. A ductal diameter greater than 1.5 millimeters or greater than 1.4 millimeters per kilogram when indexed to weight points to a large shunt. A ratio of the left atrium to the aortic root of 1.5 or more indicates that the left heart is being volume loaded. A ratio of left ventricular output to superior vena cava flow above 4 says that a lot of the heart's work is being wasted on the shunt. A mitral valve inflow pattern with an E-wave to A-wave ratio above 1.5 reflects raised filling pressure in the left atrium. On the duct itself, a diastolic velocity below 1 meter per second marks an unrestricted, wide-open vessel. And the hallmark of systemic steel is flow in the descending aorta that is absent or actually reversed during diastole, with the same reversal seen in the celiac artery, the superior mesenteric artery supplying the gut, and the anterior cerebral artery supplying the brain. No single one of these is sufficient on its own, but several together paint a convincing picture of a duct that is harming the baby.
This is the most important safety slide in the whole lecture, so let me be emphatic. Before you treat any duct, you must be certain that the heart is structurally normal. There is a group of congenital heart lesions in which the entire systemic circulation, or the entire pulmonary circulation, depends on the duct remaining open. In these babies, the duct is not the problem, it is the lifeline. If you close it with a medicine, with a device, or with surgery, the baby can deteriorate and die within hours. The lesions to think about are hypoplastic left heart syndrome, critical coarctation or an interrupted aortic arch, critical aortic stenosis, pulmonary atresia, critical pulmonary stenosis, and transposition of the great arteries, where the duct allows the 2 parallel circulations to mix. The rule is simple and absolute. Confirm a structurally normal heart before you treat a duct. And if you are ever in doubt, do the safe thing, which is to keep the prostaglandin infusion running to hold the duct open and get an expert echocardiogram, rather than to close a duct that might be keeping the baby alive.
Now we come to the argument that has divided neonatology for half a century: whether to treat the duct at all, and if so, when.
The history of how we treat the duct is best pictured as a pendulum that has swung back and forth for 50 years. In the early decades, the instinct was aggressive. We closed ducts prophylactically and early, on the assumption that an open duct caused harm, and that closing it must therefore prevent harm. The trial of indomethacin prophylaxis in preterms, published in 2001, was a landmark. It showed that prophylactic indomethacin did reduce severe brain hemorrhage and the need for later closure, but crucially, it did not improve survival free of disability at 18 months. That disconnect, fewer ducts but no better long-term outcome, planted the first seed of doubt. Over the following 2 decades, the pendulum swung steadily towards tolerance, driven by the studies I will show you next: the PDA Tolerate trial in 2019, the Benedictus trial in 2023, and the Baby Oscar trial, reported across 2024 and 2025. Each one pushed us further towards patients, and they culminated in the 2025 American Academy of Pediatrics report that I will come to shortly.
Let me give both sides of the argument fairly, starting with the case for closing the duct. There are 4 serious arguments in favor of intervention. The first is mechanistic plausibility. We have already seen that a large shunt overcirculates the lungs and steals blood from the gut, the kidneys, and the brain, so relieving that shunt ought to help the baby. The second is that the biggest and earliest ducts genuinely do cause harm. A wide, pulsatile duct that persists in a ventilated, extremely premature infant is associated with pulmonary hemorrhage, with severe brain hemorrhage, and with death, and few people would simply watch such a duct without acting. The third argument is about chronic exposure. If prolonged exposure to a large shunt contributes to chronic lung disease, then closing the duct earlier might shorten that exposure and reduce the lung injury. And the fourth is a practical one. Unlike a great many of the problems we face in the neonatal unit, the duct is a discrete, closable target. We have medicines and we have devices that can reliably shut it. So the case for treatment rests on plausible physiology, on real harm from the largest ducts, and on the fact that we actually can close it.
Now, the other side, the case for conservative management, which is where the weight of modern evidence has come to rest. Again, there are 4 arguments. The first we have already established. Most ducts close on their own, especially beyond 26 to 28 weeks, so a large fraction of all the treatment we have historically given was simply unnecessary, aimed at ducts that would have closed by themselves. The second argument is the most powerful. The randomized trials show no benefit on the outcomes that actually matter. Closing the duct, whether early or routinely, has not reduced death, has not reduced bronchopulmonary dysplasia, and has not reduced neurodevelopmental impairment in modern trials. The third argument is that treatment is not free. The cyclooxygenase inhibitors we use cause reduced urine output, gastrointestinal bleeding, and a risk of intestinal perforation, and every procedure carries its own risks. And the fourth brings us back to association versus causation. Because the duct is partly just a marker of how immature and sick the baby is, treating the marker does not treat the underlying frailty. So the conservative case is that we have been treating something that usually fixes itself, that our treatment does not improve the important outcomes, and that the treatment can hurt.
Here are the trials that built the modern consensus, and I will summarize each in a sentence. The trial of indomethacin prophylaxis in preterms from 2001 asked whether giving prophylactic indomethacin helped. It reduced severe brain hemorrhage and the need for surgical ligation, but it did not improve death or disability at 18 months. The PDA Tolerate trial from 2019 compared early treatment with a more conservative approach and found that early routine drug treatment did not improve outcomes, while the conservatively managed babies did well. The Benedictus trial, published in the New England Journal of Medicine in 2023, was a non-inferiority trial of ibuprofen against expectant management, and it found that simply waiting was non-inferior for the composite of death, necrotizing enterocolitis, or chronic lung disease. The Baby Oscar trial, reported in 2024, tested early ibuprofen for a large duct within the first 72 hours, and it found no reduction in death or chronic lung disease, with early treatment offering no benefit and some signals of harm. And a meta-analysis by Bhuvanaswaran and colleagues in 2025, pooling active against expectant care, reached the same conclusion.
active treatment did not reduce mortality or major morbidity. Read together, the message is remarkably consistent.
Two of those trials deserve a slide of their own, because between them, they did more than any others to settle the question for the current generation. Benedictus, published in 2023, was designed as a non-inferiority trial, and it showed that expectant management was non-inferior to ibuprofen for the composite outcome of death, necrotizing enterocolitis, or bronchopulmonary dysplasia, assessed at 36 weeks. In plain terms, waiting did not cost these babies anything that we could measure. Baby Oscar, published the following year in 2024, attacked the question from the most pro-treatment angle possible. It took babies with a large duct and treated them early, with ibuprofen within the first 72 hours of life, the exact strategy that ought to work best if early closure helps. And it found no reduction in death and no reduction in chronic lung disease. The 2-year follow-up, reported in 2025, confirmed there was no developmental advantage either, and there were hints of harm. So the most aggressive, earliest treatment strategy, tested rigorously, simply did not pay off. When a non-inferiority trial of waiting and an early treatment trial both point the same way, the field listens. All of this culminated in the 2025 report from the American Academy of Pediatrics, which is the most important current statement on the subject and which crystallizes the shift towards restraint. Let me give you its headline positions. First, prophylaxis is strongly discouraged. Routine prophylactic cyclooxygenase inhibition is no longer recommended for unselected preterm infants. Second, expectant management is now the default. Routine very early or early closure is not recommended, and watchful waiting is the starting position for most ducts. Third, when you do decide to use a drug, ibuprofen is preferred over indomethacin because it achieves comparable closure rates with a lower risk of necrotizing enterocolitis. Fourth, transcatheter closure has matured into an accepted option for selected infants, broadly those above about 700 grams, and as a direct result, the rate of surgical ligation has fallen sharply. And fifth, on fluids, excessive fluid intake should be avoided in the first days of life, but the report does not endorse aggressive, prolonged fluid restriction. Taken together, the report tells us to do less, to wait more, and to reserve active closure for the babies who clearly need it.
With the evidence laid out, let us walk through the actual management options, in tiers, from simply waiting all the way to closing the duct.
Let me now go through the management options in tiers, starting with the foundation, conservative and supportive care, which is the default for most ducts. The aim here is to optimize the baby's physiology and give the duct time to close on its own. There are several components. The first is judicious fluid management. We avoid fluid overload in the first days because a large shunt gets worse with excess volume, but we are careful not to swing to the opposite extreme and dehydrate the baby. The second is respiratory support. Maintaining an adequate positive end expiratory pressure and good oxygenation helps, and a higher mean airway pressure can actually reduce the left-to-right shunt across the duct. The third is permissive monitoring. We follow the baby with serial clinical examination and repeat echocardiograms, watching the trajectory rather than overreacting to a single snapshot. The fourth is a specific warning. Do not use furosemide to treat a duct. The classic work of Green and colleagues in 1983 showed that furosemide raises prostaglandin levels and may actually keep the duct open. Fifth, we maintain an adequate hematocrit and good nutrition so the baby is well supported. And the sixth component is simply time. Beyond 26 to 28 weeks, most ducts will close by themselves. So patience is not passivity. It is an active, evidence-based choice.
When we do decide to use a medicine, every drug we have works on the same pathway, the one I asked you to remember at the very start. Arachidonic acid is converted by the cyclooxygenase enzyme into the prostaglandins, including prostaglandin E2, which keeps the duct relaxed. If we lower prostaglandin E2, the duct can constrict and close. The non-steroidal anti-inflammatory drugs, ibuprofen and indomethacin, work by blocking the active site of the cyclooxygenase enzyme directly, shutting down prostaglandin production. Paracetamol, which you may know as acetaminophen, works on the same enzyme but at a different spot, the peroxidase site, rather than the active site.
The practical consequence is that paracetamol achieves a similar fall in prostaglandin with a gentler side effect profile because it does not block prostaglandin production everywhere in the body as forcefully as the nonsteroidal drugs do. So 3 different drugs, 1 shared target. And understanding that shared target is the key to understanding both their efficacy and their side effects.
If a drug is the right choice, how do we pick between the 3? Here is a practical comparison. Ibuprofen is the preferred first-line agent. A typical course is 10 milligrams per kilogram, followed by 5 and then 5 milligrams per kilogram, given at 24-hour intervals, and it closes the duct in roughly 70 to 93% of cases. An important practical point is that oral ibuprofen is at least as effective as the intravenous form, often more so. Its main cautions are reduced urine output and gastrointestinal bleeding. Indomethacin works just as well at the same enzyme site, with a course of 0.2 milligrams per kilogram for 3 doses, but it has been largely superseded because it causes more constriction of the cerebral and mesenteric blood vessels, meaning more effect on blood flow to the brain and the gut. Paracetamol is the useful alternative, given at 15 milligrams per kilogram every 6 hours for 3 to 7 days. It works at the peroxidase site. It has the gentlest side effect profile, it is the cheapest, and it can be given by mouth or by vein. Its main caution is liver effects with prolonged use. So, in one sentence, ibuprofen first, paracetamol when a non-steroidal is contraindicated or not tolerated, and indomethacin now rarely. A few practical pearls will help you use these drugs well. First, the oral route often beats the intravenous route. Enteral ibuprofen has achieved higher closure rates than the intravenous form in several studies, so when the baby can safely be fed, use the gut. Second, respect the contraindications. We avoid the cyclooxygenase inhibitors when there is active bleeding, when the platelet count is significantly low, when there is renal impairment, or when necrotizing enterocolitis is suspected, because in those situations the drugs can do real harm. Third, watch the kidneys throughout the course. You should expect a temporary fall in urine output and a rise in creatinine, so monitor the fluid balance carefully and do not be caught out by it. And fourth, a second course is reasonable. If the duct is still significant after 1 full course and the baby remains a suitable candidate, it is justified to give a second pharmacological course before escalating to anything more invasive. Most ducts that are going to respond to medicine will have done so after 1 or 2 courses.
When medicine fails or cannot be used, the next tier is transcatheter device closure, and this is the area that has changed most dramatically in the last few years. The key development was the Amplatzer Piccolo occluder, studied by Sathanandam and colleagues, and approved in 2020 for infants as small as 700 grams. That weight threshold matters because it brought device closure within reach of genuinely preterm infants for the first time. The results are impressive. Implantation succeeds in around 97% of attempts, and the major complication rate in the pivotal trial was below 3%. In practice, device closure is best reserved for the infant whose duct remains significant despite a course or 2 of medicine, or for the infant who cannot receive cyclooxygenase inhibitors at all. Its great advantages are that it avoids opening the chest, and that it essentially eliminates the post-ligation cardiac syndrome that I will describe next. The caveats are that it requires an experienced interventional cardiology team and careful case selection, because the size of the baby's blood vessels and the baby's hemodynamic stability both matter. But the trajectory is clear. Transcatheter closure has moved from a rescue procedure to a mainstream option.
The final tier is surgical ligation, and the headline is that it is now the last resort, and it is becoming rarer. So when is it still needed? Typically for a large, symptomatic duct that has failed medical treatment and is not suitable for a device, and that often means the very smallest, sickest, ventilator-dependent infants in whom nothing else has worked. The rate of ligation has fallen substantially around the world, precisely because we treat fewer ducts with drugs, and because device closure now handles many of the babies who would once have gone to theater. The reason we avoid surgery when we can is that it carries real costs. A thoracotomy in a tiny infant risks paralysis of a vocal cord, a chylothorax from injury to the thoracic duct, and later scoliosis. And the work of Weiss and colleagues in 2014 linked ligation with worse neurodevelopmental outcomes, although some of that reflects how sick these babies were to begin with. And there is a specific aftermath to anticipate.
Up to around 15% of babies develop the post-ligation cardiac syndrome, a predictable fall in the performance of the left ventricle in the hours after the duct is tied off, which is the subject of the next slide.
Let me explain the post-ligation cardiac syndrome, because recognizing and preempting it is a genuine mark of a good neonatal team. While the duct is open, the left ventricle has been ejecting against the low resistance of the pulmonary circulation, and a large part of its output has been running off through the duct. The moment the surgeon ties the duct, that low resistance escape route disappears. The left ventricle suddenly faces the full, higher resistance of the systemic circulation. Its afterload jumps, and its output can fall. This typically declares itself 6 to 12 hours after the operation as deteriorating blood pressure, poor perfusion, and a rising oxygen and ventilator requirement. And it can be mistaken for sepsis or for a primary lung problem if you are not expecting it. The point is that it is predictable, so we anticipate it. We monitor these babies closely in the hours after ligation, ideally with targeted echo-cardiography to watch left ventricular performance, and we are ready to support the circulation with inotropic medication such as milrinone or adrenaline and to adjust ventilation. Importantly, this syndrome is essentially a surgical phenomenon. It is one of the strongest arguments in favor of transcatheter closure, which closes the duct without provoking it to anything like the same degree.
Finally, let me pull all of this into a single practical approach you can carry to the cot side, organized around gestational age.
Here is how I bring everything together into a single practical pathway. It starts, always, with the echocardiogram, and the first job of that echo is the safety step we discussed, confirming that the heart is structurally normal and excluding a duct-dependent lesion. Once the heart is normal, the question is whether this is a hemodynamically significant duct, judged on the composite of the duct, the shunt, and the baby. If it is not significant, the answer is conservative management and patience, full stop. If it is significant, then in the modern era, the default is still supportive care and close observation, because the trials tell us that early treatment does not improve outcomes. We reserve pharmacological closure, ibuprofen first or paracetamol when a non-steroidal is contraindicated, for the baby who is genuinely symptomatic, the ventilator-dependent infant with a large pulsatile shunt who is not improving. We then reassess. If the duct remains significant and the baby still needs it closed, we escalate to transcatheter closure for the suitable infant, and we keep surgical ligation as the final option for the few in whom nothing else is possible. Notice the overall shape. The pathway is built around doing less, defaulting to patience, and escalating only when the baby clearly declares the need.
Before the take-home messages, let me flag where the field is heading, because the story is far from finished. The central controversy has shifted. The question is no longer simply, should we treat the duct? Because the trials have largely answered that for the average baby. The new question is which specific infant actually benefits. In other words, how do we identify the high-risk duct that genuinely needs to be closed, hiding within the large majority that do not? That feeds directly into the second area, smarter risk stratification. Severity scores, serial targeted echocardiography, and emerging blood biomarkers may eventually let us treat the few while safely tolerating the many, which is the holy grail of this field. Third, the technology keeps advancing, and transcatheter devices continue to move towards ever smaller infants, so the boundary between what is closed with a device and what still needs surgery will keep shifting in the device's favor. And fourth, there is the question of timing. If there is a subgroup that benefits, when exactly is the therapeutic window? Almost all of our trials treated early, and a later, more targeted treatment strategy in carefully selected babies is much less well studied. Those are the questions your generation will answer.
Let me leave you with 6 messages to carry away. First, the duct is a normal fetal structure, held open by prostaglandin E2 and low oxygen, and the problem in the preterm infant is not that the duct exists, but that the process of closing it after birth fails. Second, most ducts close on their own. Beyond 26 to 28 weeks, spontaneous closure is the rule, so patience is an evidence-based strategy and not neglect. Third, significance is a composite judgment. Weigh the duct, the shunt, and the baby together, and treat the stage, never the murmur. Fourth, and never forget this,
Exclude duct-dependent congenital heart disease before you ever close a duct by confirming a structurally normal heart. Fifth, the modern trials favor restraint. Prophylaxis is out, expectant management is the 2025 default, and ibuprofen is the first-line agent when you do decide a drug is needed. And sixth, escalate only for the few. Reserve device closure and surgery as a true last resort for the symptomatic duct in the baby who clearly declares a genuine need. If you remember nothing else, remember that in patent ductus arteriosus, doing less is usually doing more.
These are the key references behind everything I have presented, anchored by the 2025 American Academy of Pediatrics report and the major randomized trials, Benedictus and Baby Oscar. The full citation list is provided, so you can read the primary sources for yourself, and I would encourage you to read the 2025 report in particular, because it is the single best summary of where we now stand. Thank you for your attention.